Welcome, everybody. We're so excited to kick off our second session of today's Target Pulmonary Embolism Virtual Connection Forum. I'm Alexa Cohen, a program consultant at the American Heart Association and your co-host for today. This event is made possible through the American Heart Association Target PE Initiative, a 3-year quality improvement initiative supported by Inari, now part of Stryker. With that, it is my pleasure to welcome you to this session, the practical implementation of the 2026 American Heart Association American College of Cardiology Acute PE Guidelines. This is going to be a great one because we have a case review and a panel that will highlight early real-world experiences implementing the new 2026 guidelines. Our 4 panelists will share approaches, challenges, and any early lessons learned as their institutions have begun aligning their workflows and protocols with the updated PE recommendations. Before we get into that panel, we'll kick things off with a brief case review from Dr. Mona Ranade, who will be going over 2 cases and a few common challenges clinicians may face when applying the new guidelines in clinical practice. Dr. Ranade is a Stanford-based vascular and interventional radiologist, a national trial principal investigator, and was one of the co-authors of the 2026 PE guidelines. Dr. Ranade, with that, the floor is all yours.
Thank you so much. Thank you very much for the invitation, and I'm excited to get things started here. So I'll start off with the case, and we see these type of cases not too infrequently, unfortunately, at Stanford. This is something that we've had to really figure out how to classify these sort of complex patients. And I know this slide seems really wordy, but trust me, the context is really important to how the classification then works out in this case. So here's a gentleman, he's 63-year-old male, significant cardiovascular history, hypertension, hyperlipidemia, AFib. He's had ablations in the past. He comes in with aortic root aneurysm, aortic stenosis, severe regurgitation with left ventricular dilatation and reduced systolic function. So, because he had recently developed some exertional dyspnea and underwent evaluation, they decided he needed a bioroot replacement, ascending and hemiarch replacement, as well as left atrial appendage closure. So, I put the dates in here just to give you a context. So, the procedure that he underwent was extensive. Post-op day 1, the patient was extubated but was noted to have acute global aphasia. And despite the aphasia, he was able to follow commands. So a code stroke was activated, a CT was performed. He did not have any large territorial infarcts. He did not have intracranial hemorrhage. He did not seem to have any seizure activity. Neurology evaluation did show that there may be some concern for distal cerebral ischemia, and they had recommended an MRI. However, the patient continued to decompensate post-procedure, requiring exceeding oxygen requirements and other vasopressor support. And as the patient's clinical status deteriorated, they actually had a PERT consult. And at this time, patient was considered really unstable, too fresh from the surgery, and the PERT discussion was to just observe the patient. In the next 2 days, the patient continued to deteriorate, required reintubation, needed hemodynamic support with epinephrine, dobutamine, needed nitroglycerin, and inhaled nitric oxide for improved oxygenation. Cardiothoracic surgery at this point did approve high-risk heparin infusion, and the PERT was activated again. When we had the discussion for PERT, which at Stanford is the ICU team, the team that's presenting the patient, IR, and CT surgery, we looked over the imaging. The patient was still requiring epinephrine, dobutamine, nitroglycerin, and inhaled nitric oxide. And let's go over the imaging here. So the imaging did demonstrate bilateral pulmonary emboli with moderate to high burden, and you will see the lobar clot extends into the segments. The important thing here to notice is obviously the aortic root repair, and you can see that the RA and RV are both dilated. There's also significant collapse of the right lung. There are bilateral pleural effusions as well. And so the concern here was also how long has this clot been there? Did this happen intraoperatively? Um, is it possible that the patient has started to form some infarct? This would be potentially post-op day 4 of this acute PE. And so we go on to the next slide, and this here is a decision support tool that I created to kind of aid our interventional team in assessing the consults and applying the ACC, AHA ACC 2026 guidelines classification system to each patient. It's not uniformly used across our PERT either currently. It's basically just distributed. To the IR team. And so let's just kind of go through what we had discussed on the phone call with our PERT team. So this patient, 63 years of age, weighs about 117 kilograms, symptomatic PE. You can see his vitals. His heart rate was 95, systolic blood pressure 101, diastolic 57, SpO2 was 93. Interesting thing was he had a dilated RV on all of his echoes, as well as CT, and he had RV dysfunction to begin with, even before this PE, CTPE was performed. He had moderate burden. He had elevated cardiac biomarkers and lactate throughout his admission. And so we didn't have any new information immediately prior to the CTPE. And this is a normotensive patient. However, it appears to be normotensive shock, requiring vasopressors. He did have altered mental status. He had recent major surgery. Recent stroke, questionable because we never proved it on a CT, but perhaps we would have seen something on an MRI. And then he was requiring mechanical ventilation. We did not know of any proximal DVT, and as you can see, the rest of the categories on here, this is basically a toggle on and off, and it allows you to then move over to the next page where it kind of breaks down the different categories of SPESI, BOVA, NEWS score, and in this case, the patient had a BOVA score of 4 and NEWS score of 8, and that's related to the RV dysfunction, cardiac biomarkers, as well as his O2 requirement, his temperature, blood pressure, and altered mental status. So, in this classification system, I think this patient would fall in the category D or E. But when he was presented to us, because it was normotensive shock, and he was kind of well controlled on his current regimen, I would say he was a D2. In this patient, obviously, the systemic lytics were contraindicated given his recent surgery as well as potential intracranial condition that may have been a global ischemia. However, we had not definitively ruled out stroke. PERT activation was recommended, and he was still a potential candidate for some form of catheter-directed therapy. When we did have this conversation with the PERT team, we had decided if the patient decompensates, we're unable to give him lytics, should we then initiate ECMO? And this decision was made ahead of time, where if we did not see any improvement in the patient's status, we were to call the CT surgery team to initiate ECMO in the IR suite. And the TEE, that was an interesting thing. We don't routinely have TEEs for all patients. This patient we were monitoring with echo because we were so concerned about him. We had also no indication of increased RV dysfunction. However, what was noted on the TEE was that he is appearing really obstructed and there is no pulsatility of blood flow in his PA. And so when we did the procedure, and I'll go through the procedure next, here you can see selection through the transfemoral approach of the right and left pulmonary arteries. And I don't have the all of the pictures here for you guys, but essentially the PA-gram shows that you have almost this tortuous appearance of each of these blood vessels with some filling defects, and you're definitely not seeing all of the parenchyma. And that is to indicate that there is some blood flow getting through, which is why you're seeing sort of this tortuosity of the blood vessels instead of nice, beautiful, linear blood vessels. And also there's lung collapse here. But essentially, there was significant thrombus burden. You can definitely see it on this left-sided, right-sided PA-gram right here, the third image. And we were able to do aspiration thrombectomy. And the discussion then was that the patient was not very stable. However, his RV function did improve on the TEE, as well as his PA pulsatility was improved. And usually that's not the outcome I'm looking for. Usually the outcome I'm looking for at the end of any procedure is, did we get the clot out? Did the did the SpO2 improve? Did the blood pressure improve? And it seemed like here we were kind of going off of other surrogate outcome measures that perhaps we are not used to using each time we do these procedures. Decision was made that he was not oxygenating well despite all of our pulmonary thrombectomy, and we definitely had gross clot specimen to prove that. And so VA ECMO was initiated, which was later then converted to VV ECMO. So the patient was in the hospital for over a month. At 1 month post-op, you can see that we have definitely reduced the thrombus burden in the main lobar branches, and there's lumen creation distally into the segmental branches. You see contrast kind of going further out. There is some pulmonary infarct, but as I just said, the patient was in the hospital for over a month and is, just basically now getting to a point where he is more stable. So the gray areas of discussion, how do you interpret elevated cardiac biomarkers in a patient with ongoing cardiac issues? The same thing can apply to someone who may have elevated lactate because they're septic. How do you interpret shock in someone that already has other factors that they might present with? And we frequently see this at Stanford, where the patient's just so critically ill, and if they develop a PE, it's kind of difficult to really apply the classification system at that time point. And I think some of it has to do with the news score, which may actually be useful because if you apply the classification system at different time points as you do your evaluation of the patient may escalate, and then they might switch categories as well. So they might go from classification D2 to E1, and then you can kind of make your decisions about what is the appropriate next best step. So that's definitely something that we've had to deal with. The other things that are not included in the classification system, things like, when someone has lung infarctions, and, whether or not CDT with lytics would be appropriate in that case, would aspiration be appropriate in that case, the questionable hypoperfusion of the brain, if someone doesn't have a clear-cut CT that's showing stroke, or whether a CT is even obtained in these patients to evaluate for any stroke, then where do they kind of fall in the treatment algorithm? And then the one thing that have not included here was this additional factor of basically looking at the PA pulsatility and whether or not the PA is obstructed using echo. I mean, these are not things that we've initially relied on. We look for McConnell sign, we look for RV hypokinesis, dilation on echo, and perhaps my fellow panelists can kind of talk about these things if they ever come up in their practice, but certainly we have considered doing escalation of care with CDT for patients that might even be lower on their classification system, where perhaps treatment with CDT was not proven when the classification was made or when the guidelines got written. But there are certain patients with ongoing O2 needs or ongoing dysfunction on echo. And if then we kind of go straight out of the guidelines to then take the risk of potentially doing catheter-directed therapy for these patients. So that's my case, and I would, love it if we could move on to discussing how others are dealing with these issues and if they're seeing them in their practice and so forth.
Thank you so
Thank you.
much, Dr. Ranade. That was a great presentation, very insightful, and the work you've done with the PE Compass tool is also very impressive. With that, we're going to transition to our panel. I'll be moderating today's discussion, and joining Dr. Ranade, I wanted to welcome our three other panelists from Froedtert Hospital in Wisconsin. We have Dr. Matthew Scheidt, a vascular and interventional radiologist, PE response team lead, and IR residency program director. We're also proud to welcome Dr. Lisa Baumann, a hematologist and medical director of antithrombotic therapy. And last but definitely not least, we welcome Dr. Jamie Aranda, an emergency medicine physician and ED medical director at Froedtert. As a quick reminder, full speaker bios can also be found in the event lobby if you'd like to learn more. But diving straight into our first question, the cases that Dr. Ranade shared highlight how to apply the new guidelines in real time. For the broader panel, with these real world gray zone cases, how do you build systems that ensure consistent guideline aligned decisions across different teams and settings?
In silence, I'll answer that one. Um, I think it's really important, and I know this is part of the next forum as well, but building the per team, this is where it comes into play. These are the little nuances of who do we treat, why do we treat, are they still on, required O2, have they been in the hospital for 3 days and they're not getting better? You have to have the right team. You have to build the team, find out locally who is honestly passionate about PE, and kind of and follow that and meet regularly and have that team. I mean, these gray areas are basically every PERT call that we get, there's a little bit of a gray area, right? Guidelines are great, but they're guidelines. And I think the gray areas are the absolute reason why it's been shown that PERT teams are so important.
Yeah, I just wanted to add, I think in Dr. Renate's case, patient that has chronically elevated troponins, they have known like right heart, strain at baseline. It's just can be very challenging. So I do think that multidisciplinary conversation with, a group of folks that are going to be involved in the patient's care can be very helpful in kind of parsing out what's going to be the trigger or, determine that there's been a change in clinical status and what the plan is for the next step so that we can plan for it, ahead of time. I thought that was another nice thing that she highlighted is having that plan in place ahead of time so that, when I'm bedside in the emergency department resuscitating somebody, I'm not, trying to jump on another PERT call. We already talked about what the next steps are. So, yeah.
Yeah, I would just add to the point of, anytime that for any guideline panel or any guidance that you write locally, I think the main aim is an 80-20 rule is what we use. We want it to, be perfect for about 80% and be applicable to the rest of the 20, that you have to then use the art of medicine and your clinical judgment to really make decisions. And that's exactly where the PERT team comes in.
Yeah, definitely. Thank you all for those thoughtful responses. Given how important the multidisciplinary pulmonary embolism response teams are, especially with the new guidelines, I wanted to ask you all, what does an effective PERT model kind of look like under these new guidelines, and what are the most common challenges and potential implementation barriers as well?
Take that. So I think I recently started at Stanford. Prior to this, I was at a different program with a very different PERT model. And I think that in my prior experience, because of the history and how comprehensive the PERT program was, including specific coordinators or nurses or someone to look at the data, as well as kind of keep track of sort of like a red cap of events that might happen, as well as a very good, robust system of follow-up for these patients. Um, I think that patients with PE, with the use of some kind of AI tool to one, diagnose a PE, have another system to actually have the discussion in a very streamlined, effective, non-cumbersome way for all physicians, as well as then to have a plan for follow-up. It was well implemented and it was well formed, and as well as kind of known across the hospital system. So going from that system to a new system where there was no formalized PERT until this year. We formed our PERT in February of 2026. Although there are passionate individuals that do care about the PE patients, there was no formal implementation of this sort of multidisciplinary consortium, right, in our system. And I think I'm seeing the differences of things where there's a little bit of coordination of care that's lacking in terms of should we give lytics? Should we do half dose lytics before the patient comes to IR? Has there been a formal follow-up plan that's been figured out for the patient? Who's going to follow this patient? And then another thing that I struggle with and I'm still working on hopefully implementing is this hospital-wide recognition of this PERT program. So as it turns out, our medical ICU colleagues are very attuned to, uh, you know, having these PERT calls and discussions because a lot of them are part of the team that is involved in forming our PERT, but the SICU colleagues do not know about the existence of PERT. And so it's really trying to get out to neurosurgery and other surgical programs and going to their ICUs and kind of letting them know that we are doing this and there are opportunities for us to collaborate. And the pilot that we started only consisted of CT surgery, MICU, ER, and IR. And once that pilot prototype is proven to be effective, then the plan is to roll it out to all of the other surgical colleagues. So those have been some of our struggles as well as kind of a learning curve early on. And I think this is month 3 or 4, and we're just kind of starting to expand.
Thank you so much. That was very insightful. And I think it's super important that we definitely talk about like some of the struggles of kind of choosing between lytics and catheter-based therapies and all that with the new guidelines that are being implemented. So thank you for touching on that. I wanted to ask Dr. Aranda specifically, as the medical director of Froedtert, how do you think that teams in the ED should adjust triage and risk stratification to kind of align with the updated guidelines without slowing throughput from more of the ED service line standpoint?
Yeah, I think this is, kind of this is a great topic because I do think that it's, of course it's a balance, right? There's, we're trying to be good stewards of our resources, but, in any environment, we tolerate errors of, commission much more than we do omission, meaning like a lot of the time people are more comfortable ordering a CT scan on somebody and reassuring the patient they don't have a PE than say like missing a PE. So I do think that, Dr. Baumann and myself, we've done a lot of work trying to really hardwire the clinical decision tools, and trying to reduce those times to, CT. And I think if we are CTing everybody, that's, definitely creates a backlog. And I'm sure lots of other places are dealing with this too, but just trying to be mindful of resources. I was going to point out, there's a lot of information in the new guidelines, and I think we, us three here from Froedtert have talked quite a bit about, some changes that we need to make to our algorithm, but I think a lot of the themes are still there, and we have a, great foundation in place, but there is an added level of complexity to the new guideline that I think is going to be hard to kind of wrangle hundreds of physicians and APPs and residents to kind of recognize this. I was just going to call out, there is a really nice resource on the AHA website. There's some take-home messages specifically for emergency physicians. And, I would encourage anybody, who's working with the ED or medical director to take a look at those, because I do think it's a really nice like 2-page tip sheet that highlights some of the implemented changes and talks about some of the clinical decision making tools as far as like age adjusted D-dimer. There's also some comments I think in the guideline about streamlining and doing things in parallel, which honestly I think is pretty typical of our practice already, but I just wanted to call out that resource to help kind of tackle some of those challenges. It's very helpful summary that might be a little bit more palatable for forward facing for our frontline staff.
And I think really the collaboration with the emergency department is very essential, right? Because they're the ones that are making that diagnosis first, and having those protocols in place to get all of the biomarkers up front. So then they have them at the time that the PERT call happens, and then people can be appropriately risk stratified. The other point that we haven't put in yet also is about anticoagulation. And one of the main changes of the guidelines also is very much a preference and a call out for use of low molecular weight heparin instead of unfractionated heparin. And the place that we really need to do that is in the emergency department. Because what we have seen, it's human nature that once something is started, it's much easier to just continue it. And so really having that first decision about anticoagulation in the emergency department is very essential.
Yeah, I just had two quick comments and then I'll let Dr. Scheidt say, I think I saw you look like you're about to say something, but I do think that in the guidelines, it does talk about like the, time sensitivity and getting the treatment on board, especially, in those cases where we are waiting hours, like, it can take a very long time to, get patients to CT when you're dealing with, some of the volumes and acuity that we see. And then the second point I wanted to make is I lean heavily on my colleagues, Dr. Scheidt and Dr. Baumann Kreuziger, because they are, excellent content experts and partners. So I handle the logistics and the operations stuff, but that partnership has been very, very helpful. Dr. Baumann Kreuziger and her team have a whole menu of pathways and protocols and resources available that not only that we can use in the emergency department, but that primary care and urgent care and some of our other system physicians can use to also try and route people to the right place so that we're not sending everybody to the ED to get a CT scan and or get started on anticoagulation, that we can work some of this stuff up elsewhere.
Definitely. Thank you guys all for talking about just the importance of collaboration with the ED and just across all specialties. And obviously, a lot of these changes will take time for adoption. We are getting close to time, so I wanted to ask one more question to wrap up. We just wanted to ask you guys, do you have any pieces of advice to share with other hospitals nationwide who might be watching? Maybe if a hospital wanted to implement these guidelines tomorrow, what do you think are the first 1 to 2 steps that you would recommend taking?
At this, I don't know that that's it's going to work. I think there's a lot of steps to it. As Dr. Ranade said, there's a lot to starting this. And there's a lot of roadblocks that you'll hit as you start a per team and kind of implement these new guidelines. Just as an example, 6 years ago or 7 years ago, when we kind of reinvigorated our per team, it took us probably 2 or 3 years to even start using the nomenclature: low risk, intermediate high risk, intermediate low risk, and high risk instead of submassive and massive. And so it was an educational thing. And it's time consuming. You have to have people that, again, care enough to educate the people, even on the calls, micro dosing of education, I say, like on those calls, you can educate the people, the practitioners, providers that are initiating these calls. I think the biggest takeaways that I have for starting this and implementing right away is get away from heparin and go with the guidelines and I agree, low molecular weight and we've been doing it for a couple of years, but I think that's important. Get your buy-in from your per team members to reach out and educate, whether that's grand rounds, whether that's educational modules in your system, whether that's literally walking into each department and shaking hands and introducing yourself. I think that's important. And then, just determining what is the best way to educate a large system with multiple hospitals, with community hospitals, academic centers. I mean, it just goes on and on, right? So I think there's a lot to it. It does take time. Starting it tomorrow, like you suggested, might be impossible, but I think you can start somewhere. And I think these guidelines are as good as any. And if you're starting new, use the new guidelines. They are very similar. They're just, they have different letters and numbers, but they actually correspond pretty close to the old nomenclature.
Just wanted to also mention one group I think we are missing here from our team is just the pharmacists. So we have Dr. Young, anticoagulation pharmacist that helps a lot with this work as well. But in the emergency department, we have a team, at least at our site, of emergency medicine pharmacists. And frankly, engaging them has been one of the most high yield parts, I think, of making sure people are actually following the guidance, because they will call you out if you're ordering the wrong medications, and also they do a lot of teaching for our patients that we do end up sending home and follow up in our anticoagulation clinics and stuff too. So our group of pharmacists is much smaller than our group of emergency physicians, so sometimes I use them to help champion some of this stuff too.
Thank you all so much for such an incredible discussion. It's super engaging, and thank you for the work that you do every day. And thanks again, Dr. Ranade, for your presentation earlier. Unfortunately, we're at time, but coming up next at 12:05 p.m. Central, we have our third session of the day, Building a PE Program. This session has 2 model shares and another panel discussion, so we'd love to see you there. To access the next session, please click the link directly in the chat, or you can also exit this session and return to the lobby using the menu at the top of your screen. From the lobby, click on the Sessions tab and then click on the individual session to join. Thank you everyone so much for attending. We will see you soon in the next session.